Agitation, as you know, is one of the symptoms of Alzheimer's disease that is highly prevalent. In one meta-analysis cross-sectionally, we expect about 40% of people at any point in time to have agitation. But it can be higher than that. We know that agitation, the prevalence also increases with the severity of the underlying cognitive impairment. So by the time you're looking in a long-term care facility, 50 and sometimes higher percentages than that can have agitation. The reason why it's a problem is because it's associated with a decreased quality of life in persons with dementia. One of the major diagnostic criterions is just that they have to have distress in association with these symptoms. So you can see that if you see your loved one in distress, it's hard on the person with dementia, and it's also hard on the care partners. It's associated with increased mortality as well as decreased quality of life, increased use of physical restraints like sitting in their wheelchair and having the tray put up, especially if they have resident-to-resident aggression once they're in a long-term care facility. So that's one of the reasons why we treat it. One thing that everyone agrees on about the management of agitation, that the first step has to be non-pharmacologic interventions. So first is the investigative part. You evaluate the person and make sure that there's no other cause for the underlying agitation. They could have an underlying urinary tract infection that hasn't been treated, or they could be catching an upper respiratory tract infection. So you make sure that there's nothing else going on when they have agitation that's new or has gotten worse. The next thing that you have to look at are concomitant medications. We know that some concomitant medications can contribute to agitation. And we also know that even though there isn't strong evidence that shows that the Alzheimer's disease medications treat agitation, we know that they can help with the emergence of agitation. So you would also want to make sure that cholinesterase inhibitors and memantine are in place if it's appropriate. Once you do that, if there's still no response and the agitation is still meeting diagnostic criteria and severe and interfering with the patient's quality of life, then you would start thinking about pharmacologic interventions. Even then, you would start with interventions. For example, if the agitation is mild, you might try citalopram. It's if the agitation is moderate to severe that you would think about using atypical antipsychotics. That would be the first line. And of course, if it's very acute agitation, then you would have to give an acute interventions like something IM. But if it's moderate to severe agitation and it's the person is at risk of self-harm or harming others, you would start thinking about an atypical antipsychotic. That would be first on the list. And brexpiprazole, for example, was recently approved for that indication. Next on the list are things like nabilone that you might try. That would be second line.